pleasure to be here. Honored to have been invited, and I'm glad you guys have stuck around until the end of the conference. Traditionally a thin time, but it looks like a pretty good turnout. Galloway, I work at New Leaf Treatment Center. I work at a straight-up outpatient drug treatment center, but my background is more actually in research, outpatient treatment of addictions. So I know about the treatment side. It has been the focus of my career, but I'm not just a treatment guy. I also am involved in studies where we administer MDA, MDMA, salvinorin A to people, and have a sort of broader perspective on the field, perhaps, than some people who are just in the treatment arena. So effective treatment, so treatment of what, I think, is one of our first questions, and I think all the panelists may have something to say about what is this thing that we're treating, but I think addiction is a great word for it. I think that is sort of the distinct entity that needs to be addressed. There are a variety of different sort of definitions that go flying around, and my background is mostly in pharmacology, so it's very appealing to think about, oh, what's the drug doing, what are the receptors, what are the withdrawal symptoms, what's the tolerance and all that. And it's a little difficult for a lot of people in the public to get, I think, that it's not really about those things. It's really a disease of your relationship to the drug. Or is it compulsive? Is it compelling? Is it ongoing? Is it interfering with your life? The rough and ready definition that I use is it's addiction to a substance is if there's a craving, strong desire to use it, a compulsion, you feel like you can't help yourself, and continued use despite adverse consequences. There are more detailed, lengthier definitions. The American Psychiatric Association has their DSM-5 and 10 criteria, and if you meet 2 or more, then you have a substance use disorder. That's 10. You only have to meet a very few to meet criterion there. Tolerance and dependence are a couple of them, but again, tolerance and dependence are neither necessary nor sufficient, and it's really your relationship to the drug, and is it interfering with your life? It's a very practical sort of thing. And I will get back to what effective treatments are, and I think I'll turn it over at this point.
Good afternoon. My name is Mike DiCipolla. I'm the director of the Stonewall Project with the San Francisco AIDS Foundation. I am the director of an outpatient drug and alcohol treatment program that is designed fully as a harm reduction program, from walk-in lounge type services for drug users to come in and just hang and chill and feel okay, being acknowledged and being human beings, all the way through more intensive programs where people can come in and have a counselor and have a psychiatrist. So I'll talk more specifically about some of the goals and objectives related to that programming that I'm responsible for. When I think about the term addiction, I think one of the things that comes to me is that it's not really about me and my understanding of the word or what it means to me, but my job really is to really be relentlessly tuned into what the needs, objectives are of those that come in and want to talk to me. So primarily I want to find out what these terms mean to someone else. I particularly don't think the term is particularly helpful for myself. I feel like it reduces some of the issues that people manage in a way that feels shameful for some people. But I'm really happy to embrace the models or the ideas that make sense for each individual person that comes in to see me, so we can create the most effective plan together to take a look at their lives, their health, their love, their well-being, their connection to community, their connection to themselves, and their acceptance and ability to hold on to hope for themselves. So I also don't like ideas that absolve people from responsibility. I don't know that that's always particularly helpful. And certainly I could have lots of debates about that for individuals as well. But again, I'm happy to embrace ideas and concepts that work for those that I serve in their service together. I see myself as a partner. I see myself as someone with expertise. I do not, and I never see myself as the expert. And what I realize in doing this work and in thinking about effective work overall is there's no one way. There are many. And my real job is to kind of work with people to figure out what the hell is going to work with this individual person. Where is this person coming from what place in the country, from what place in the world, from what place in terms of religion and upbringing and community and society, etc., to come up with what works for that person and that person alone. So each, in my way of looking at kind of holding hope for people and helping them get to a place of hope themselves, it's really about, the first thing is to make friends. And we were talking earlier today, I was observing someone talking about MDMA-assisted therapy and things like that, and how you have to have the relationship, you have to connect, you have to join, you have to have, it seems stronger than a therapeutic alliance to me. But I really make connections with the people I serve, and I really let them know that I give a shit about who they are, and that they're important to me, and that them being able to thrive is important to me, and I think it's possible. It's not always easy, but I've seen many people do it, and I've seen them do it very successfully. Whether that means that they want to still use some drugs and not others, and that works for them, or they need to abstain from one or more things because they've determined that methamphetamine doesn't work for them, and alcohol doesn't work for them, but they can smoke pot once in a while. I help people figure these things out on their own, and I don't have judgment about what they choose to do, but I do have a lot of reality, and I don't rub their noses in it, but I help them to see what's really going on so they can make choices for themselves. I think I also, as I'm kind of thinking about, effective treatments, I also want to talk about, the intersection between HIV infection and transmission, also the intersection between mental health and mental health disorders and substance use disorders. And, frankly, when someone comes in to see me, I'm often not concerned which has come first, the substance use problem or the mental health problem, or maybe they all both came at the same time. All of that gets to get unfolded and understood further as we start treatment together and understand how to make their treatment, their plan, their goals work for them. The other thing I guess I will say in kind of closing is that, I've been doing this work for over 20 years. I started in the world of HIV prevention more so, but one of the biggest issues in the world of HIV prevention, infection, and transmission is substance use, and also mental health issues for gay men in particular who have been thrown away, denied their sexual identity, treated as pariahs and lepers in their communities. So dealing with a lot of that trauma and dealing around what that creates for people's risk for the infection or transmission of HIV was how I started to approach this work, and then drugs and alcohol was always a part of that as well, and then sexual orientation and understanding who you are as a sexual being so you can have a happy, healthy, satisfying sex life, and maybe play with drugs and maybe not play with drugs, but not need them in order to do it. And finally, I'll close just by saying that when I put together programs, I put together programs with people that are not technicians, but people that know how to show love and compassion, and that really are in it because they want to be there. They care about drug users. They care about what we do. Many of them have their own personal experience with drugs and alcohol, as I do, and they know lots of things. And there's also lots of things they don't know. And they're really in it to be in the journey with someone, as challenging as you all know that can be sometimes. We kind of have we have a statement that at my program, it's kind of the program of last resort for a lot of people, because other people won't tolerate how challenging they can be. And I don't personalize it. I find a way to release that energy, but I acknowledge the pain and suffering that people come in my program to manage, and try to find creative ways to help them get past that in whatever way that is necessary for them. So everyone is welcome in my program, regardless of whether they're using chaotically, psychotic, or they're still living the hells with great jobs, and anything in between.
Okay. Hi, I'm Pat Denning. I'm the Director of Clinical Services and Training for the Harm Reduction Therapy Center in San Francisco and Oakland. And we provide outpatient, primarily dual diagnosis services for folks who have the full range of both substance misuse and emotional or psychiatric disorders. I'm going to back away a little bit from my program and the treatment model of harm reduction therapy, and we'll certainly talk about that later or with questions. But I want to give an overview of my thoughts about this entire question. And the first thing that I think is really important is to remember that both drug use and drug misuse is first a social justice issue. It's first a human rights issue. And, and what that means is that we who are working with people, who are doing clinical work with folks, must always be activists. We have to always be involved in the politics of what it means to use or not use or misuse drugs in this society. It also means that we've got to watch our language. If we're going to think about human rights, then we have to stop using words like clean and dirty, which is only this far away from sick and only that far away from evil or immoral. And we also have to be careful of words like alcoholic. Beverages are alcoholic, people are not. So again, we have to think a lot about the language that we use. And so when we start thinking about the term addiction, it's a word that I have always been really comfortable with because it's a lot easier than saying substance use disorders, or problematic substance use. It just rolls off the tongue a little better. That doesn't mean that I think it's a very good term, and I try not to use it. But one of the main problems with it, though, is that it captures only a particular small point on the continuum of drug use and drug use problems. Addiction is sort of an end point, if you will, of problematic drug use. Although I sort of make another end point for folks and call it chaotic drug use, which is, addiction squared. But it doesn't capture the fact that some people have small problems with drugs. Some people, of course, don't have any problems with the drugs they use, but some folks have small problems, and all we've done so far is pay attention to the big problems and offer treatment as if everybody's problem is exactly the same. So I think that problems with drug use are really a biopsychosocial process, where the relative weight of biology and psychology or sociocultural factors are different for each person, and really need to be explored with the person and evaluated, so that one person's addiction to alcohol can be very different from another person's addiction to alcohol. And trying to formulate a treatment as if there's one particular thing that we should pay attention to doesn't really make sense, and I think is part of the reason why most of our drug treatment fails people. And the other thing that is really important to me is to remember that addiction is not a disease. It is not a brain disease. Now, of course there are brain changes. I'm a psychopharmacologist. I love neurobiology. I love reading all this stuff and looking at the brain, and by studying it, I'm just more and more convinced that that's an overly simplistic way of looking at what's a really complex phenomenon that changes over time. And of course there are brain changes, and of course some of those brain changes make it more difficult for people to resist or to turn around some of their drug use. But it's only one piece of what's going on with the person. So calling addiction a brain disease it's too simplistic. It leaves out any context of the person's life or the person's situation. The brain imaging studies that we're all so crazy about these days have nothing to do with functional impairments. All they are brain changes, and nobody's talking about is these brain changes actually hurting anyone in their life. But I think even more importantly, when we keep calling problems with substance use as a brain disease, it leads into what is happening in the field now, which is the medicalization of substance misuse. And I've watched the medicalization of emotional problems. I came to California in the late 70s to be part of the community mental health movement, only to see it overtaken by the realm of biological psychiatry. And what we've ended up with now is that schizophrenia and depression and anxiety are brain diseases. They're now the purview of medical professionals, and they're best treated by drugs. So now in most community mental health programs, you can't get psychotherapy because you can't do psychotherapy for a brain disease. So I see that history, and I see that happening again now in the field of substance abuse treatment, is that, and what happens then is that the focus shifts once again, the focus of control and power shifts once again from the client, away from the client, and gives the power to physicians primarily. It continues, the medicalization continues the bias that biological factors are primary in substance use disorders. It focuses and limits research on treatment on primarily medicines, procedures, and what we love to call evidence-based practices. Don't get me started on evidence-based practices, but ask a question and I'll get on my soapbox about that. The medicalization also retains an abstinence bias. And finally, I think it does not reduce stigma. That's one of the arguments for it. That's been one of the arguments for the past 20 years, is that if we call addiction a disease, then people aren't bad. It's not a moral judgment. And I think what we've seen is that the medicalization has not reduced the stigma. We still see people with drug problems as bad and immoral and gross and all of that stuff. So it's really a fallacy that this is going to reduce stigma. And in particular, to call substance problems a chronic relapsing brain disease gives a whole new definition to you'll never recover. You can only be in recovery. You'll never recover because this is a chronic brain relapsing disease. You can never be trusted. You can't trust yourself, and other people can't trust you because God knows when your brain is going to take over. You know, so I think then the other thing, I'll just say one thing about treatment, which is that we need to really talk about treatment and what works and what are the different modalities and kinds of treatments and theories and all that good stuff. And what that means is that we need to get AA and 12-step programs the hell out of treatment. They are not treatment. They were never meant to be. They are at their best when they function for what they're meant for, which is a spiritual community. You know, a self-supporting spiritual community. And in that way, they have a place within all the services that we can offer people, but they are not the primary place and they don't constitute treatment.
Hi everyone, I'm Dan Werb. I'm an epidemiologist from Vancouver looking at HIV and addictions. All these opening remarks have been terrific, and I feel really honored to be here. I'm not a treatment provider in any way. I look at, sort of a population level factors related to HIV infection and addictions. And what's really interesting about Vancouver is that, there's been a really strongly advocating community of people who use drugs in Vancouver for decades, who have really, in a lot of ways, directed the type of research that's been happening there. And it's had an incredible impact on, focusing research on the many sort of structural factors that affect what we call, problematic drug use or addiction. And for those of you who are in the heroin-assisted treatment session, obviously there's so many questions around this. Like, is someone who uses heroin by injection every day with a needle that is sterile a problematic drug user, or is someone who uses heroin by injection once a month with a potentially contaminated needle, is that problematic drug use? And those are the sorts of questions that I think need to be posed to people and policymakers to really sort of get a little bit more granular when we're looking at ways to, improve the health of and the social outcomes of people who use drugs. A lot of the research that I've been doing recently has been focused on, what we call the risk environment, and that's looking at how there's an intersection of there's a policy environment, a geographic environment, and an economic environment and a social environment. And they're all intersecting, they're all overlapping, and they're all constraining the range of choices that people have to avoid risky injection or drug-related behaviors. So for example, when I think about how best to treat problematic drug use at a population level, what we found in Vancouver is that and this has been repeated in settings across the world, is that so many of the transitions into problematic drug use, into injection drug use in particular, are facilitated by people who inject drugs. And we've done research in Vancouver, and what we found is that, when I talk to people who inject drugs in Vancouver, it's very clear that there is a stigma against initiating someone into injection drug use, right? You're never supposed to inject somebody for the first time. But when you're operating in a survival economy and you are heavily dependent on drugs, forcing people to make impossible choices that often bring in a moral aspect is incredibly difficult. So for example, if I'm a heroin user that uses heroin every day and needs to use heroin every day or else I get dope sick, and I do not have that heroin because I do not have the money, and somebody approaches me and says, if you inject me, I will share my heroin with you. I mean, there is no best choice in that scenario. What you've got is someone in a position where they're only able to rationalize two very, very, problematic choices. So that's just to illustrate the fact that when we think in our setting about treating problematic drug use, that it's really about thinking about transitions into injection drug use and into problematic drug use, but not just in terms of the individual themselves, but in terms of the environment that they're operating in. And I can speak more about it. I don't want to take up too much time, but certainly, there's a lot of different ways that you can think about, well, how do you reduce the pressures on people to inject other people, or how do you shape social networks in a way that problematic drug use is sort of reduced within the population. And I'm not a treatment provider, and I'm actually really excited to hear about the experiences of people who are working directly in this world, and hopefully I can offer just a slightly different perspective. Thanks.
Good afternoon. I'm Scott Kellogg. I'm a clinical psychologist. I'm now in private practice, and I teach at New York University. In my history, I've worked in frontline clinics of various different kinds, methadone, traditional diagnosis. And I've also worked in a number of research settings. I think Gans and I met at this night at CTN a number of years ago. In 1988, I entered the world of substance abuse treatment. I actually worked with homeless people when homelessness was a temporary problem in New York City. Whoops. Yeah. We thought we were going to solve that problem back then. But it became clear to people, if you worked in homelessness, that many people had addiction problems. And I was able to get a job actually in graduate school. And in those years, working in those frontline clinics, I was fundamentally appalled by the way they treated people with addictions. That the disrespect, that what we considered to be the bare minimum of psychotherapeutic courtesy and respect, completely violated. Not by everybody, and not all the time, but enough to be horrified at what I saw. And so out of that became kind of a basic mission of mine, that we need to bring psychological and psychotherapeutic treatments to people who wrestle with addictions. And that's been a driving force in my work, and I would say specifically individual psychotherapy. I'm going to get to this later, but in my opinion, there's no substitute for individual psychotherapy. Many things are helpful, many things are catalytic, but there's no substitute for that sacred encounter in the sacred space of the therapist and the patient. But the question is, why were these patients treated so badly? And I think that, and Pat, I think sometimes we take different routes to get to the same place, perhaps, in our journey together. I think basically there have been two paradigms at work in the field of addiction treatment. One paradigm is that these are bad people who need to be punished, and this is the world of treatment I'm talking about, not drug policy, right? In the world of treatment, we're not, we don't live in a different culture, and by the way, the patients often believe they're bad people who deserve to be punished, right? They internalize that one. And a model that these are sick people who need to be healed. And for I'd say the first 15 of the last 25 years, I think the punitive model was definitely dominant in my experience, working with in clinics, doing research. In the last 10 years, I think we're beginning to see a sea change here, where it's really about, that these are people, and I think they are sick, they have a psychiatric disorder, mental illness of sorts, at the most extreme end, not everybody obviously uses substances, who need really good treatment, need humanistic treatment, need cared for, profound respect, et cetera, et cetera. Most of these people have mental health issues, or if not, huge issues with self-hatred, huge issues with trauma, and huge issues with anxiety and fear, right? And that's at the heart of this experience for many people. So my work more recently is on the issue of, we look at people's lives, we look at people who change and heal and transform. What are the psychological mechanisms? What are the psychosocial mechanisms? How do people get better? How do they transform? How do they heal? How do they claim a new identity, a new life? What are those mechanisms? Can we consciously use them? Can we make them part of our treatment and use them in a purposeful manner? I think we use them haphazardly, or maybe intuitively, but I think it's better if we can consciously say, this is a path. These are the ways that people get better. Just in terms of this addiction issue, I like the word addiction because at this conference we see many people saying drug users. And I understand the use of the word drug user as a universalizing or normalizing experience. We're all drug users on one level. But on another level, it's clinically not sophisticated because people have a whole gradation of problems, right? Some people have no problems, recreational users, slightly problematic, more serious problems. But some people really are addicted with devastating disorders, which devastate themselves, people around them that go on for years, that bring oceans of pain, grief, suffering, and anguish to this world. And I think, language that captures that, because I think we, paradoxically, and even some of my colleagues, we trivialize addiction. We don't take it as a very serious, like as if we're cancer or something, the way we treat people is like they have a trivial problem. This is a serious problem that needs serious, skilled professionals working with it. So, just a few thoughts, I'm sure we'll get into it later, but thank you. And I'm glad to be here, by the way.
Whatever it is, we're drug use, drug misuse, drug abuse, addiction. Is it useful to conceptualize it in those ways? And I want to twist, put a little spin on this, because one of the things I deal with, and I think a lot of folks here as advocates deal with, is, this is a complex area. It's a contested area. And often when we're advocating with legislators or the general public. And I think one of the reasons that people, whether they agreed with it or not, often use addiction as a brain disease was because I do agree that it doesn't do away with the stigma, but it was something people could understand. So if I could twist this a little and ask you all what you think is a useful way to conceptualize this, I think both, clinically for people who go a little more in depth, but for our efforts in terms of a broader public that might need something, we have to meet people where they're at. And if you don't have a background, how do we explain to people what this issue is that we're here talking about?
Well, I would agree that it's extremely complex because it is a bio-psychosocial, spiritual disease, and it really encompasses all those dimensions. And the environment as well. I think Pat brings up a really good point, and I want to speak up for the other panel member who couldn't be here, Carl Hart. He has a wonderful book out. He talks a lot about the role of environment, talks about the rat park experiments. Typically when we do animal experiments to look at addictiveness of drugs, addictive behavior, not sure rats can be addicted, but anyway, things that look like addiction in animal models, typically those are done in isolated, single-housed rats. And so you can control everything, you know exactly what's going on, you know how much they eat, if all rats are treated equally. But rats are social creatures. And so it turns out that when you put rats in an enriched environment where they can play, where they can interact, where they can copulate, I think I read a description of Rat Park recently, using that particular word, where they have free access to food, it's very difficult to get them to self-administer these drugs that we're taught. The pharmacology is that they're really reinforcing. It's not that they're really reinforcing in a vacuum. It's choice of alternate reinforcers. It's like, what's going to make you feel good? We all need to feel good somehow. So that has all sorts of implications for how you do animal research. It also has a lot of implications for prevention. I mean, we know that really impoverished areas where people don't have things that are going to bring them pleasure, whether rewards for their good school performance, self-satisfaction, social activities that don't involve drugs. So that needs to be addressed on a societal basis, but it's a little beyond the scope of this talk. I do, though, keep thinking about those experiments in the context of drug treatment too, because we talk a lot about, oh, you need to do this, or we need to form an alliance, or things that happen within the context of that setting in which the treatment or harm reduction is done. But they also need to have fun. That's got to be the part of the prescription for effective drug treatment, or I would say probably harm reduction as well. And there is really, I do think there is this sort of distinct phenomenon where people do slip into something that I like to just call addiction as a shorthand, that does involve this craving and compulsion and continued use. But even that does come on a real spectrum. We have great data from alcohol with 20-year follow-up of people, and of those who are alcohol dependent 20 years later, a vast majority get off, no longer have alcohol dependence, or no longer addicted to alcohol 20 years later. Most of those have no formal treatment, no contact with any sort of treatment program. They get clean and sober, sorry. They get off alcohol without intervention, and that is not really a studied or appreciated or recognized group. Yet those who have milder addiction, if we can stop them from progressing to something more severe, that's an ounce of prevention. I'm not sure even a pound of cure is going to get very good success rates given the way our treatment system works. And I'm going to keep talking about treatment a little bit more, diverge into that. There is a lot of confrontation in the system. There's a lot of even addict-delivered treatment, which is quite confrontational. In fact, I think a lot of the people in recovery are some of the most confrontational in terms of treatment programs, and we now have data. Confrontation is bad. We think it's bad, we don't want to do it, it sounds bad, but they're good, firm data that approaches that more roll with the client and what they want and what they need and where they are. Motivational interviewing, for example, are much more effective than confrontational approaches. There is an effort as we try to, do experiments and organize knowledge to try and identify, what sort of treatment is going to work best for which people. National Institute on Alcohol Abuse and Alcoholism funded a huge study, 750 subjects, 250 per group, trying to match up, what sort of clients are going to do best with motivational interviewing, more rolling with where the clients are, cognitive behavioral therapy, more sort of directing them, this is going to help you not use, 12-step facilitation, all these hypotheses about what's going to help. They're basically all wrong. We don't know what's going to help an individual up front until that relationship is established, until you start working with that person. So it really requires some degree of eclecticism, it requires some degree of small c Catholicism, and I think even more broadly than choice of psychosocial therapy, a lot of us work in our own little silos based on the sort of treatment setting we're in, or the sort of training we have, or the sort of personal background we have, but it's really important to take the time to identify and be willing to identify, it looks like you need methadone maintenance. It looks like you need a therapeutic community. It looks like you could do with outpatient treatment. It looks like this is not addiction, but I'm concerned that you're injecting once a month and I want you to go see the harm reduction folks. And that, I think, is a real missing piece from the system that we need to find a way to get put into the system.
And if I can just do moderator's privilege, and just if we could also, we can go off script, but if we could also address a little of what is it we talk about when we leave this room. How would it be more helpful for those of us who are advocates to talk about this issue to whoever in the public?
Well, when I think about kind of framing whether or not we use the term addiction, and whether that's the term that we all have to embrace in order to come to an understanding, I think, the reality of the matter is life is simple yet complex, and all of us are not so simple that we can't understand that there's a continuum of possibilities that exist in the world for people around these matters. And if I think more people came out of the closet about where they are in their own lives with their own drug use, for instance, me as a drug user in my life, where am I on that? And how do I identify to others in that? And am I shameful or out of the closet about that, as I am right now? I think that's, we laugh, but I think it's a really critical area here, because I think what happens is, the masses think that they don't know anyone who uses drugs and alcohol. They don't know anyone who's successful. They don't know anyone who's not on the street. Well, that's really not true. So let's all come out of the closet and start from there. And then when we come out of the closet, in lots of different ways, we can really talk about the fact that there are many people who use substances recreationally or just to reduce stress, and there's many people who use them to play in really profoundly mind-blowing ways. But maybe they do that in a balanced way, where they do the rave 3 times a year, and then they might have a drink once in a while. And how is that harmful? And I think that we could evaluate with an individual and looking at their lives whether or not they're maintaining relationships, they're missing work, there's really serious consequences, there's damage to their body or other things that are happening because of the way, the style, the how and whys when they're using. Are they hydrating? Are they do they not know how to slam, and they're slamming and they're injuring their veins? So there's lots of different things we could look at. So when we come out of the closet, I think we can come out and we can understand that there's a large spectrum of possibilities available for people, and that, in my opinion, it doesn't really matter whether or not people play with drugs and alcohol. It really matters whether or not their lives work for them. And as a culture, are we saying to each other that, hey, we care if your lives work for you. If your life works for you, great. That's a great thing. But if your life isn't working for you and something's going on and you're feeling anxious and depressed and you're using for reasons to hide and not deal with the things that are going on or inability to cope, then let's talk about how we can get you some help to move forward with that and not to feel like you have to use any substance to be able to not deal with emotions or not deal with trauma or to hide from things that are really deeply troubling you and debilitating you in lots of ways in your life in order to move through with healthy, meaningful, connected relationships with yourself and with others. I do want to say that as I kind of talk about my notion and concept of this, I think I will go with whatever someone's concept is, and I will understand it for them and figure out how that makes sense for the treatment goals that we put in place for them as an individual. But I personally think that we need to move much further than beyond the term of addiction as a way to understand these matters. When I think about treatment, and I think about treatment in a place that I create along with my teams, I think about a place where people are welcome and they don't need to be well before they get help. They don't have to be better. They don't have to feel good. They have to stop using. They can come in high. They can come in crashing. They can come in psychotic, out of their mind. And they are welcome. The thing that's challenging for people that create programs like my program is we have to find multiple ways, many ways, to be able to have people come in whatever place they're in that's not disruptive to the other levels of care within the facility. So you have to start from walk-in, centers that just allow people to come in, have a pizza, maybe get some coffee, get some love, get treated with respect, where the staff actually wait on them and get up and get them a cup of coffee and say, hey, welcome, how'd you hear about us? How can we help you out? And or if someone can only sit for 10 minutes and they really want to come in and find out what's going on, they come and sit for 10 and then they go. And maybe they'll come back in after a cigarette, and they might do that 15 times in the matter of an hour. But you know what? If we start in a place of accepting someone where they are, sometimes that's exactly where we have to start. And that's not always easy for us as human beings. We need a little more control than that, don't we? So we have to first start to kind of take a look at ourselves and what we're willing and not willing, comfortable, not comfortable doing in working with other people. And come to terms with our ability to kind of sit without being able to fix something immediately. To be able to come to terms with being able to listen to someone, hear them out, have them know that they are being heard in a really profound way, and not do anything about it to start. Just be. It's a very powerful place. And it changes people's lives very slowly sometimes, but it creates this, what I mentioned earlier, you know, one of the big goals and objectives of people coming into treatment is being able to hold hope for people before they can hold it themselves. So, you know, when you treat someone like that, and they come in and they can be kind of crazy in the way they're kind of crazy, and they don't get judged for that or get put out, they're not required to function up. Now, I'm okay with programs that need people to function up, as long as those programs would say, this is our level of care. You have to be in this place in order to be seen here. And if you're not, this isn't the right program for you. But here's a program over here that's right for you. So, you know, my goal in looking at programming is I have programs that go from website to harm reduction information, which is one of our sites is tweaker.org. Check it out. Which gives health education and information for people that are never going to come into our center, but really want to know the medical, biological, social implications of using methamphetamine and how they might make changes themselves, how to hydrate, how to conceptualize harm reduction, how to think about how much drug you're putting in your body and even understand what that means, especially if you're trading for drugs and other things like that. So it ranges from those kind of activities to more intensive services as people are ready. When someone can sit for half an hour, cool. Then you have a half an hour to do some work with them. And as people are ready, you know, a variety of different types of groups, but it's not one model fits all. So if someone can't come to a more traditional drug treatment group because they have a hard time talking about drugs, then maybe what you do is you do a book club which actually has a lot of principles of harm reduction and other things, and then people start applying it in their lives, and they do it in a really easy way it almost feels tricky, but it's totally not. Or things like, we do acupuncture, we do massage, we do yoga, we do meditation, we do mindfulness, and all those types of activities to get people connected in their bodies. And then some of the more challenging things for people are coming to see psychiatry, doing some other one-on-one. But I think all of those services are wrapped with an incredible sense of love and respect. And everyone that participates in the program, in a successful program, in my opinion, is involved in the design, implementation, and delivery of the service. So that means that you hear from people by way of written evaluations. We do them every 3 months in my program. You go out and you visit them in their individual sessions and in their group sessions, and you hear from them what's working, what's not working, what do you need, what don't you have here. People will tell you that oh, the trauma group is really working for me. It's really amazing the skills that I'm learning right now. It really helped me be able to understand how I can evaluate weights and measures and understand how much drug or alcohol I'm putting in my body and really know so I can make good choices for myself. So I'll get more into some of that, but that's kind of what I'm thinking about effective treatment.
You know, I really agree that we all need to come out as drug users. You know, I like to say that, you know, some of the best experiences of my life, you know, occurred under the influence of some drug or another, and actually none of the worst experiences of my life occurred under the influence of drugs. So, you know, there you have it. But I do think that's important, as in all stigmatized movements, that the more of us come out, whether or not you've ever used illegal drugs, doesn't matter, come out as a drug user. I think in terms of advocacy and language, I'm really glad I don't have your job. You know, because as a therapist, as a trainer, I can talk about all sorts of complexities and whatever, but my limited experience with politicians is that they act as if they're stupid. I don't think a lot of them are, but they really have to have sound bites. And concepts are Concepts aren't really great. But if you're going to move away from brain disease, I don't think you have to move away from the term addiction. I think you have to move away from brain disease. And what I'm imagining is that somebody who's really good at graphics can come up with a very simple, 3 circles, biopsychosocial, that interact. Just a nice graphic with little bit of copy in there, that says, Joe is 40 and depressed and uses alcohol, but Jane is, 18 and, wants to dance. That's a little bit much, because I think the other thing I think is you can't talk too much about the continuum of substance use with politicians, because they don't want to hear that people use drugs. They want to hear about treatment. What are we going to do with those problem addicts, basically? They want people to stop, and so I think that's kind of where you have to meet them with that. But I do think some kind of a graphic that shows, the brain's involved, but emotions and psychology are involved, and the person's social situation is involved. That's the message that I think needs to be given about how to define addiction, and then what's the cure for it. If you're going to stick with addiction, the cure for it is a variety of treatment models that address all of those different things and don't ignore anything. So I think that's kind of the way I'm thinking about, but I don't know anything about advocacy, so.
I just want to say one more thing about advocacy. When you think about substance use, and especially for gay men and other queer populations, methamphetamine is a driver of the epidemic, as is powder cocaine, crack cocaine, and alcohol. So, you have to use that as an advocacy to talk about how it's moving the epidemic. And if we want to eliminate or reduce the epidemic of HIV in this country, we have to address drugs and alcohol.
Yeah, the whole question on language is so interesting. And stepping back, I think it's really important to remember that we're not, the language that we use hasn't just arisen in a vacuum. Since the 90s, even before, but we can quantify it since the 90s, the US government has spent over $1.2 billion on anti-drug ads. And they know they're ineffective, they know that they don't do anything, but the audience is obviously not youth who might or might not use drugs. The audience is the general public who is exposed to messages that talk about drugs in a very dichotomous way. People either use drugs and they'll die, or they don't use drugs. And that is, I think, this is an ongoing thing. Obviously, DARE is in schools everywhere. It's the same sort of thing. Again, proven ineffective, but and it's beyond thinking about unintended consequences. You can think about unintended consequences, but it's actually, these are intended consequences. People are supposed to be exposed to these programs and then have this conception of what drug use is, and it's really dichotomous. So, I think when you're doing advocacy, it's important to remember that, you're pushing back against an industry that is a multi-billion-dollar industry. And it's pervasive through our media. In fact, the White House was found to have contravened anti-propaganda laws with their anti-drug ads because they would place them as if they were newscasts or news stories. And they wouldn't reveal that what they were showing actually was misinformation about drug use. So that's just to contextualize things. I think from an advocacy perspective, it's important. In terms of language, I'm not a clinical anything, so I get uncomfortable using terms like addiction. But when you're, the experience that we've had in Vancouver is really about making drug use safer. So there's been a supervised injection site that's been implemented. There's been a massive expansion of needle and syringe distribution across the city. And, when you just look at it at face value, these are programs to make drug use safer. And again, I come back to that example, is what is problematic drug use? Is it someone who uses a potentially contaminated needle once a month, or someone who uses a sterile needle every day? And these sorts of issues, I think, are better encapsulated when you use the term like problematic drug use, because you can start thinking about, okay, well, who is it problematic for? You know, is your drug use problematic for the community? Well, if you do not have access to clean needles, or, you know, sterile needles, and do not have a way to safely dispose of needles after you've used them, well, your drug use is problematic for the community, but it's the community's responsibility to then provide services that can address the risky parts of your personal drug use, and that go far beyond, you know, where you're at in terms of your own drug use. And I think, you know, that's why I think about public health from an advocacy and sort of population level perspective, and that's why I find it useful, because you know, it's important to think about. Yeah, I mean, if you talk about problematic drug use, the implication is that everybody, or many more people, are using drugs, which is obviously the case. And it's about reducing the problematic elements and really diving into what those problematic elements are. Are they the drug use themselves and how they're going to impact the individual, or are they the fact that there are structural factors that aren't present or are present that are making people's drug use itself riskier for themselves or their communities?
Well, I've never even thought about the question you asked, so I don't think I'm going to answer it, but I'll answer a question you didn't ask, the one that's meaningful to me, perhaps. That's right, I guess. With the societies, the person has the conch gets to speak, right? This is it's the equivalent of the microphone. So my efforts have been more within the world of addiction treatment, you know, kind of what are we doing? So first of all, I think that addiction treatment is failing quite dramatically, and I think that, you know, in an ideal world, we would be having a national conversation about the fact that we're not treating people successfully. I think nobody wants to have that conversation openly, but it's going on quietly and indirectly. I think actually the night of CTN was some ways to have that conversation in a quieter way, that treatment wasn't working. One of the great blessings of my life is I collaborate with Andrew Tatarski, who's actually in another panel right now. And we did a roundtable in New York City where we invited people from as many different perspectives as we could bring together. So we had harm reductionists, people from therapeutic communities, people from private practice, psychoanalysts, people in public settings, physicians. For 2 days of conversation, people presenting what works in your experience. How do people get better? And here people could speak safely, right? They weren't in their treatment setting. Then we actually looked at the themes that emerged, and we kind of created a questionnaire, sent it back to the participants, and said, what do you endorse? And what was interesting was that almost pretty much regardless of your background, people knew what worked, and people agreed to what worked. And the things, I'm doing this from memory, but the things that emerged as the most highly and very highly endorsed ideas. Therapeutic relationship is absolutely fundamental. That people have inner pain and suffering, some of the things I said before, that must be addressed. Openness to gradual change, harm reduction. Even the TC people said harm reduction, absolutely necessary. And cultural sensitivity, broadly defined. You know, there were other things on this study as well. But to my mind, we know in many ways what works. And if we go to our humanistic side, I think we can find much better solutions for patients. And many things that you were saying, I think, fit into this gradualistic models that we talk about of change and healing. Just parenthetically, I thought that was an interesting paper. I had a hell of a time getting it published. It was this interesting. The field was very resistant to this idea. Who cares what you think? But we eventually got it published. Anyway, just that said something to me about. I thought this was such a compelling idea. All these people come together and commune and find common ground. But whatever.
Okay, I want to make sure the audience has time to.
There was a recent report on treatment, on what works in terms of treatment, and it was very surprising because it was really clear that the treatment for not only drug-related things but psychological and psychiatric, the treatment that works best is long-term psychodynamic informed psychotherapy. Other than that, medium to long-term cognitive behavioral therapies work pretty well. The problem is that once you stop therapy, you don't get any better after that. And sometimes you get worse. With longer-term therapy, you continue to get better over time, even once you're out of therapy. So we've got the evidence that says people need a long-term therapeutic relationship for significant difficulties. That's it. We're not ever going to get that in this country. And so, I think that, I'm not sure what to do. I'm really despondent about it, and we've ended up at the Harm Reduction Therapy Center in this situation where we have a private clinic where we take no insurance because we would lose money because the insurance pays so little compared to what we can actually charge. And so we see upper middle, and upper class people in that setting. And then we work in community-based agencies where we work, we have contracts with those agencies and see people for free. But there's everybody in between that is not getting seen by us. And in San Francisco, the Bay Area, there's tens of thousands of people that we ought to be working with who have insurance that won't allow them to get treatment, or have insurance that pays so little that most of us who are doing the treatment won't accept it. So I don't know what to do about it.
Well, and I think overall the concept of induration is a really great thing. It's noble in its idea, but we have to make sure there's enough behaviorists within the practice to be able to see people that are getting referred to them, and that's enough time from everybody, and that everyone's not being asked to do more with fewer and fewer resources, which is always the problem with these type of things. But I think truly if in primary care more people are thinking about sexual orientation and substance use and what people are doing to live and thrive and survive, whether it's adoptive or not, is a problem, and we need to be able to do better with that in primary care and in settings where there's integrated care, where people can see someone and talk about drug use even if they don't feel like they have a problem, etc.
One quick thing. In the San Francisco Bay Area, there are 15,000 licensed psychologists. There are 35,000 licensed marriage, family, and therapists and clinical social workers. If each of those people worked with 2 clients, we could see everyone who needs care for a long period of time.
It's very strange for me to hear a question and perspective about over-medicalization of the field, because from my perspective, I see it as a grossly under-medicalized field. First of all, almost nobody gets treatment. The treatments that are available are almost always delivered in settings where the medical personnel are secondary in their role or altogether absent. So I don't see medicalization as a problem, quite the opposite. Specifically, and we haven't really talked about this yet, but with respect to opioid addiction, methadone replacement, placebo-controlled trials long ago reduces mortality 80%. This is an amazingly good treatment in the context of medical field, almost getting up to surgical sort of rates. France made a decision to make buprenorphine widely available for treatment of opioid dependence, and they saw a greater than 80% reduction in opioid overdose deaths nationwide. So they just made a policy decision that was tremendously beneficial. We have some buprenorphine in this country, but it's restricted because I would say the treatment field is under-medicalized, and also because there are payment issues.
If I could jump in on that, I would agree. I mean, I'm not an expert in various treatment approaches, but certainly the scientific literature is pretty overwhelmingly positive in terms of methadone. I mean, it obviously does not work for everyone, but that's why secondary treatments like heroin-assisted treatment are being developed. The issue is that only 8% of those in the United States who would be eligible for methadone have access to it. So, that is a really, really difficult situation, and I think one of the approaches is certainly, you know, complementary treatment approaches, where it's been shown that methadone, along with CBT or other behavioral sort of interventions, can be really, really effective.
So I think we talk about medicalization. I think Pat and I may disagree on this a little bit. I mean, it's the scientific model. And the things we're talking about here with, you know, relapse prevention, motivational interviewing, contingency management, harm reduction psychotherapy, these are scientific psychological approaches. We're in the same tradition as medicine. So I think what may be going on is poor medical care if they're doing 10 minutes. But you know, before that we had non-scientific, non-medical treatment for addiction. So I think what I might say medicalization is a vast improvement. We're finally taking these people seriously. They have an illness, they need treatment, not bad people that need to be punished. So I think medicalization, the scientific, which I think we're at the beginning of, by the way, I don't think it's just beginning to truly understand people compassionately and scientifically. This is a vast improvement. And so maybe, I'm sorry it's going to your clinic, but I think this is progress.
Ken, could we just do one? We've had someone waiting here for a while.
Okay, I just wanted to make one thing clear, is that I'm a psychopharmacologist. I was part of the original training group to become a prescribing psychologist. I love medical treatments. You know, we do a lot of psychopharmacology in our center. What I'm concerned about is having what is being talked about right now in the California Association of Addiction Medicine is to make sure that physicians take their rightful place as the head of all addiction treatment. And that is where it's going. You know, and in our center, the doctor is a part of the team. The doctor does not lead the team. We have no medical director. I'm the clinical director. The doctor's part of the team, and we use a lot of medicines. To me, the problem with methadone is that it's low. You have to go to these, you know, federally funded clinics where oftentimes people are treated like shit. So, you know, we have an office-based opiate program where we are able to use methadone in some cases, but mostly we use, you know, Suboxone.
Thank you.
One of the things that we did was actually take the book that I wrote, Practicing Harm Reduction Psychotherapy, and rewrote it for the general public so that we could actually address some of these issues of stigma in a way that lay people and potential clients could read. And I think that's part of the way, is to really get people talking about, I mean, harm reduction is an umbrella. And under that umbrella is included everything that helps reduce harm, you know, including 12-step self-help groups, including, you know, abstinence. You know, it's just all part of that. But I think that having people understand that it's all about taking care of yourself, that's, you know, that whatever way you manage to do it. And I think that politically what we need to make sure of is that there are enough options.
Let's grab one more question.
Actually, I